Good morning, friends. In this video, we'll discuss a rarely discussed topic, that is in-stent restenosis. This patient with recurrent right hemispheric symptoms on initial DSA showed a tight right internal carotid in-stent restenosis of more than 90% at the origin. The incidence of significant restenosis was low at 6% with CAS and 6.3% with CA at 2 years. When monitored up to 5 years, the rate rose up to 8.5% with CA and 10% with CAS. Though moderate restenosis was common after CAS, the stroke rates were much higher with CEA. Overall, the risk was extremely low following CAS and CEA, and in the first 24 months, it was considered due to neointimal hyperplasia. Beyond 24 months, it is considered due to in situ atherosclerotic disease. It is interesting to note that despite significant restenosis of more than 70%, ipsilateral stroke rates were extremely low at 0.8% over 4-year period in asymptomatic patients after CAS and at 5% at 3 years in CEA patients. Because this patient was symptomatic, it was decided to intervene. You notice the microwire going across the stenotic site, following which we deploy a filter distally and do a balloon angioplasty proximally. Thereafter, a self-expanding stent was deployed, following which a 5 mm balloon angioplasty was performed to achieve better wall apposition. Despite this balloon angioplasty, you notice that there is a gap between the newly deployed stent and the initial stent, and this is because of the plaque that is being compressed onto the wall of the stent. When faced with such a situation, the first option would be to consider a balloon angioplasty, preferably with a drug-eluting balloon. However, the problem is that of restenosis. The second option would be to use a drug-eluting balloon angioplasty followed by a self-expanding stent. And if the stenotic segment is too short, one can use a drug-eluting coronary stent. The last option would be to use a cutting balloon angioplasty in calcific resistant stenosis. Thank you.